and we're going to talk about Chapter 25 on the respiratory system. And basically what we'll talk about is the anatomy of the upper and lower respiratory tracts, kind of like what we've gone through in lab. We'll talk about the lungs, and then get into some ideas of pulmonary ventilation, the mechanics of breathing, how the nervous system plays a role with your respiratory system, and gas transport, and a little bit on aging and different kind of an introduction to pathophysiological concepts like emphysema and asthma. Now, in terms of the general functions of the respiratory system, we know that it's involved with exhalation and inhalation. And inhalation is sort of the inflow of air into your lungs, and then exhalation is the outflow of air out of your lungs into the atmosphere. Some of the other main functions include gas conditioning. And by conditioning, we mean that gases are humidified and warmed before they get deeper in your lungs. That way, like cold or dry air doesn't damage your lung tissue. We also know that it's involved with sound production, because if you're speaking or producing noises, that's going to involve using your respiratory system and your larynx. It's also involved with olfaction or smell, because you have to be able to breathe to smell. And it's involved with defense, because we have lots of immune cells and lymphatic tissues that are associated with our respiratory tract. Now, we can really divide the respiratory system into two main zones. We have a conducting portion and a respiratory portion. The conducting portion is basically all of those structures of your respiratory tract whose sole purpose is to just transport gases into or out of your lungs. That's the conducting portion. The respiratory portion are the microscopic structures of your respiratory tract where gas exchange occurs. And what I mean by gas exchange is I mean the movement of gases basically between air and your blood. That occurs in the respiratory portion. Whereas the conducting portion, there's no gas exchange that's occurring there. It's just basically airflow, either into or out of your airways. But the respiratory portion is where gas exchange occurs. Now, we can see in this picture the entire respiratory tract. And remember, the conducting portion is just basically what conducts air. So from your nasal and oral cavities, down through the pharynx, through your larynx or voice box, down the trachea, and then splits into the bronchi, which then splits like 25 times or more down into the microscopic structures of your lungs. That's the conducting portion. The respiratory portion we can't see here because they're in the microscopic areas of your lungs, and that's where gas exchange occurs. Now, we can also divide the respiratory tract into upper and lower portions. Now, this is not the same as conducting and respiratory zones. The upper respiratory tract are all of those structures that are superior to the larynx. So we talk about the pharynx, your oral cavity, nasal cavity, and the associated paranasal sinuses. Like that's part of your upper respiratory tract. Lower respiratory tract is everything else that's larynx and beyond, right? So larynx, your trachea, the bronchi, and then bronchioles, alveoli. All of that's part of your lower respiratory tract. So if someone has an upper respiratory tract infection, we're talking about an infection that's superior to the larynx somewhere, right? Somewhere along the pharynx, the nasal cavity, or paranasal sinuses. If it's a lower respiratory tract infection, we're talking about something that involves the larynx and beyond, or distal. So, the trachea, bronchi, and bronchioles. Now, we know that we have two lungs, and they're situated in the thoracic cavity. Now, they sit just superior to the respiratory diaphragm, and the respiratory diaphragm is one of those muscles that's involved with ventilation or airflow, and it's going to contract and basically help bring air into and out of your lungs, and we'll talk about that later. Now, we'll first talk about the anatomy of the upper respiratory tract, and we'll start with some external anatomy here. So earlier in lab, we talked about how a lot of your nose is actually made of nasal cartilage, which is hyaline cartilage. There are some nasal bones that support the structure of your nose as well, and the function of the nose is to basically help draw air into or out of the nasal cavity. So looking at the nasal cavity here, what we see are the concha. So you have the superior, middle, and inferior nasal concha, as well as their associated meatus. So the superior meatus, middle meatus, and inferior meatus. And these meatus are basically where the paranasal sinuses drain into. So the frontal sinus, sphenoid ethmoidal sinus, and the maxillary sinus, they drain or connect to these meatus, or openings within the nasal cavity. Also at the superior part of the nasal cavity, we'll find up here is called olfactory epithelium, and this has our olfactory receptor cells for smell. That's at the very superior part of the nasal cavity. Now the nasal cavity leads into the pharynx, which is posterior here, and we can divide the pharynx, which is a muscular tube, divide that into 3 zones. We got the nasopharynx, oropharynx, and laryngopharynx. And then in the nasopharynx, we can see things like our pharyngeal tonsil, our opening to our eustachian tube. And then in the oropharynx, we have things like our lingual tonsil, our uvula, as well as our palatine tonsil. And then the laryngopharynx is right here by the larynx, which has the epiglottis nearby. Now, kind of zooming on this and seeing some more detail here, we can find our nostril or nasal vestibule. And this opens up into the nasal cavity, which is a pretty large cavity. We're only looking at half of it here, by the way. So this could be like the right half we're looking at here of someone's nasal cavity. But each part of the nasal cavity is separated by a nasal septum, which we can't see on here. Remember, the nasal septum is made of the ethmoid bone and the vomer, as well as their associated cartilage. And that nasal septum separates the 2 halves of your nasal cavity, which basically means the right nasal cavity is separated from the left nasal cavity. And the purpose of this is to understand direction in terms of smell, right? Like you can smell direction. We understand that something can smell like it's coming from a particular area, like to your right or to your left. And the reason why we know this is that if you're inhaling a lot of molecules through one side of your nasal cavity more than the other, then the smell is going to be stronger on like your right olfactory bulb versus your left, and that gives you a sense of direction, right? So that way you can kind of know where a smell might be coming from. Now, what's also pretty cool too is when you inhale air, it gets mixed around very rapidly by our meatus here, or concha, sorry. So you have superior, middle, and inferior nasal concha. They're these little bumps you find in the nasal cavity, and their role is to basically help mix that air around. The purpose of mixing the air around is, first of all, to help you smell better, because if you mix that air, you can smell more of the molecules in that air. And second to that, the purpose of mixing the air in your nasal cavity is to warm and moisten that air. You want to warm the air before it goes down into your lungs because you don't want cold air like potentially burning your lung tissue. You also want to moisten that air in your nasal cavity because you don't want dry air to go down in there and dehydrate some of the deeper structures. So that's the function of these concha. Now, associated with the concha, we have our meatus, right? It's a superior meatus, middle meatus, inferior meatus. This is where the paranasal sinuses open up into. The function of these paranasal sinuses, like the frontal sinus or sphenoid ethmoidal sinus, is to lighten the skull and also aid in the production of sound because these sinuses act as large echo chambers. Now, in the posterior part of the nasal cavity, what we find here is the nasopharynx, which then leads into the oropharynx and laryngopharynx. Now, all of this is the larynx right here, you guys. And the larynx is basically like your voice box, and it's made of a series of cartilages that are involved with helping to produce sound, as well as assist in the Valsalva's maneuver, which we'll talk about here in a minute. And this is showing on a cadaver. So this is actually a view from a cadaver. So what they did is they basically cut through the skull, and you can see like a mid-sagittal view on the cadaver. You can see it looks a little differently though. Like these aren't as symmetrical as you might assume. But you can see the sphenoid sinus here. It's a pretty large space within the sphenoid bone. We got the pituitary gland nearby. You know, ethmoid sinuses nearby too, and then frontal sinus would be up here. We got our concha, so superior, middle, and inferior nasal concha, as well as their associated meatus, which are those connected to the sinuses. You can see our nasopharynx, and that opens up into the the pharyngeal tonsil right here, as well as the opening to your pharyngeotympanic tube. Do you guys see this little divot here? It looks like a big, deep space. We call it the nasopharyngeal recess. There's people who can control their uvula really well, and they can hide things back there. So I once saw this guy. He's like, I don't know, like his whole act is like he can hide coins inside of his body, and like what he'll do is he'll pretend to swallow them, but I'm pretty sure he's hiding them in this nasopharyngeal recess. But what's cool, he has so good control over this. If he puts like a quarter and a nickel and a dime back there, he can bring those back out of his mouth like on demand. So he'll pretend to swallow it. He goes, and then goes, and he swallows it, right? But I don't think he's actually swallowing it. Like he says it's in his stomach, but I don't think it's actually going down his stomach. And if he said, okay, I want the quarter, he'll go, and then he'll cough out the quarter, right? I mean, it's like a magician, but like he uses his body for tricks and stuff. I don't know. I think it's called. His name's like the Regurgitator. You can look him up on YouTube. Yeah.
I've actually worked with patients who do that and just hide their pills. The nurse will open, tell them to open their mouth so they can see if they actually took their pills.
Yeah.
And we'll later find out that
Yeah.
Just hide them all over.
That's a good point. Yeah. So what you can watch, because that might be sometimes you might have to watch someone take a pill, right, and then watch them swallow it. But what if they actually exhale, like so they put the pill in their mouth, and then instead of swallowing it and go down the esophagus, what if they slightly exhaled it up into this cavity? Well, the uvula would trap it there, so you can basically hide things in your nasal cavity. So that's an interesting point. Yeah. That's quite a length to not take a pill.
Right.
But I mean, it's amazing. That's definitely a skill you need to learn. Like I don't think any of us could just do that right now, without practice. But
Yeah, well, I work with eating disorder patients, so they have like years
yeah,
of practice.
yeah, exactly. That's a good point. Thank you. Down here, you guys can see the larynx. So we have our thyroid cartilage, cricoid cartilage in the back. And here's the epiglottis. The function of the epiglottis is to depress and close off the opening to the larynx while swallowing. That way food passes down the esophagus rather than going down into your airway. And when this fails, that's what they talk about, is thing going down the wrong pipe. Like if you inhale water or something. Basically, the epiglottis failed to close off that opening. Now, this slide is showing the different regions of the pharynx with the naso, oro, and laryngopharynx. And it just talks about the functions of each, right? So nasopharynx is to conduct air, oropharynx is to conduct air or food and drink, and laryngopharynx is to conduct air as well as serve as a passageway for food and drink. And there's different types of epithelium that lines these passageways. So in the nasopharynx, we have a pseudostratified ciliated columnar epithelium. And the purpose of this is to help trap debris when you inhale it, and that way it doesn't, go deeper into your lungs. Otherwise, in the oropharynx and laryngopharynx, we find a non-keratinized stratified squamous, because this helps resist abrasion, right? Like if you're chewing on food, you don't want that to scratch up your oropharynx or laryngopharynx, so it makes sense to find non-keratinized stratified squamous epithelium. And then this part of the table just talks about what structures you find in each of these zones, which we already mentioned. Now, the paranasal sinuses include your frontal, ethmoidal, sphenoidal, and maxillary sinuses. And what this slide is showing here are basically as if you could see deep into the bone. This is what those sinuses would look like. So in purple, we got the frontal sinuses, which then would connect to like your superior meatai. In yellow here, this is showing your sphenoid sinuses, which are found in the sphenoid bone. And then in kind of I don't know, forest green or something, right here this is the ethmoid sinuses, which are also found in the ethmoid bone. And then more laterally, we find the maxillary sinuses. And these maxillary sinuses are often inflamed and infected. Now they're found in the maxilla just superior to the upper molars. In fact, it's common for people to believe they have a tooth infection when it's actually a sinus infection, because the sinus is so close to that tooth, the pain can feel like it's coming from a tooth when it's actually coming from the sinus. And back when I used to be a dental assistant, like years ago, you guys, there's been moments where, if you extract a tooth, sometimes when you take the tooth out, it extends into the sinus. So now what you find then is you can have a hole in your oral cavity that connects to the maxillary sinus. And there was one time where I saw we extracted a tooth, and this person had a big old, like a blood bubble is what I want to describe it like. And it was just kind of expanding and contracting while the person was breathing. But you can tell that's not normal, right? Like you shouldn't find a bubble that's expanding and contracting while someone's breathing, because that shouldn't open up to any part of your airway. But in this case, it actually opened up in the maxillary sinus. And if that happens, then it requires surgery where they actually do a bone graft to close up that hole. Because you can imagine like bacteria in the oral cavity could make it into the sinus cavity, and that can lead to a lot of infection. So it makes sense. Now the functions of your sinuses are to basically help lighten your skull, and apparently to also help serve as an echo chamber. Because the idea is that by having these large spaces inside your skull, while you're talking, sound's sort of radiating off your face because it's vibrating your bones inside these chambers. So the idea being that it could make your voice louder as a result. But all of these paranasal sinuses, although they are spaces within the bone, they all open up into your nasal cavity. So when we talk about sinus infections, they kind of go with nasal infections hand in hand. Now, for the lower respiratory tract, this includes things like your larynx, your trachea, your bronchi, and bronchioles. And this is still part of your conducting region. So for the lower respiratory tract, we have our conducting and respiratory zones. Most of it is the conducting zone. Remember, you don't get gas exchange occurring. You just get the conduction of air down into your lungs or out of your lungs. So that includes your larynx, trachea, bronchi, and bronchioles. And there's also a respiratory zone of the lower respiratory tract. That's where gas exchange occurs, but we'll come back to that here in a little bit. Now, for the for the the respiratory portion, that includes your respiratory bronchioles, alveolar ducts, and alveoli, which are microscopic. Now, the first structure of the lower respiratory tract we'll talk about is the larynx, also called your voice box. It serves as a dividing line or sort of marker between the pharynx and trachea. And functionally, it serves as a passageway for air. It prevents ingested material from entering the respiratory tract because it has the epiglottis associated with it. It produces sound for speech because your vocal cords are within your larynx. It also aids in increasing pressure within your abdominal cavity by Valsalva's maneuver, because when the glottis closes, it prevents air from escaping your lungs. That way it can actually increase pressure in the abdomen. It also participates in the sneeze and cough reflex because there are nerve endings in the larynx that can sense things you might inhale, which can help initiate sneezing or coughing. Even hiccuping too. So sometimes hiccups can be due to irritation of the larynx. Now, what this slide is showing you guys is just basically what the larynx looks like gross anatomically. So we find this is the thyroid cartilage. Just inferior to that, we have our cricoid cartilage. Between the two, we have the thyroid cricoid ligament, which is basically where they put the trach tube. This little anterior point of the thyroid cartilage is called the laryngeal prominence. That's the Adam's apple. The very superior part of the larynx is the hyoid bone. It actually kind of serves as a nice anchoring structure for the rest of the cartilage of your larynx. Now, on a posterior view of the larynx, we can see that the cricoid cartilage gets larger. That attaches to some arytenoid cartilage, and the very tips of this is called the corniculate cartilage. Now, the significance of this arytenoid and corniculate cartilage is that this is where the vocal cords attach. So when you're moving your vocal cords, you're actually moving them by pulling on these cartilages, and it helps move these cords right here, which you can see nearby. Here's the epiglottis, and the function of the epiglottis is to help close off the opening of the larynx, and that way it prevents ingested materials from getting down into your airways. And if you look just inferior to the larynx, this is the trachea, which has tracheal cartilages or C-rings. Now, they're incomplete, and they're connected by some annular ligaments. But if you look at the posterior part of the trachea, you see that they don't connect. This is why they're kind of in a C shape. And the muscle you'd find back here is called trachealis muscle. The function of tracheal cartilages is to prevent the collapse of your airway while you're inhaling. Because if you didn't have these tracheal cartilages intact, while you inhaled, the whole airway could collapse, right, and kind of suck in on itself because you get a vacuum there. And it would be very inefficient for air to flow in. Now, if you look inside the larynx, we find what we call vocal folds. These are also called your vocal cords. So you see your vocal cords are what anchor to the arytenoid cartilage here. So by moving your arytenoid cartilages, it helps move your vocal folds or vocal cords around. And that's going to be what produces speech or sound. So if you look at like a kind of a laryngoscopy view of the inside of the larynx, you'd see these little white tissues of vocal cord. It kind of looks like a ligament. And these are the things that are vibrating while you're producing speech or sounds from your larynx, your voice box. In fact, if you kind of touch your voice box or larynx, you can kind of feel it vibrating. Well, those vibrations are produced by air moving across the vocal cords. The vocal cords vibrate, and that's what actually is helping to produce sound. Now, while you're inhaling, this needs to be open. And so the space between the two vocal cords here is called the rima glottis. The rima glottis is just the opening between the two vocal cords. And that has to be open in order for air to pass through. And so this is actually showing what a laryngoscopic view of the larynx would look like on the inside. So you can see our vocal cords, which are kind of white. Above that, we see the vestibular fold, which is the false vocal cord or vocal fold. And this is involved with helping to close off the opening of the larynx during Valsalva's maneuver, which is when you go, huh, right? And that's actually going to help prevent air from escaping your lungs. The trachea is also your windpipe, you guys, and it's just inferior to your larynx, right? It's not very long. It's like 12 to 14 centimeters in length and maybe about an inch wide. It's supported by tracheal cartilages as well as annular ligaments, and also lined on the inside by a pseudostratified ciliated columnar epithelium. So remember, here's the larynx, and just inferior to that, we have the trachea. So all of this is the trachea. We got tracheal cartilages, right? They're hyaline cartilage. And then we have our annular ligaments. Now, the place where the trachea splits is called the carina, right? So the carina, right here, when the trachea splits, and then that splits into the right and left main bronchi. So which one's bigger?
Right.
The right. Yeah, it's hard to tell in this picture. In fact, you might even be inclined to say the left looks larger. But on average, the right main bronchus is wider and steeper, so that someone's more likely to inhale an object into their right lung versus the left. Now, if we look at this in cross-section, which we'll talk about here in a minute, the trachealis muscle you find in the back of the trachea, and it's controlled by the autonomic nervous system. So the sympathetic and parasympathetic nervous systems control the contracted state of this trachealis muscle, which also controls airflow. Now, if you look on the inside of the trachea here, in cross-section, this is the tracheal cartilage. We see that it's incomplete, right? So it's a C ring, because it's kind of like an upside-down C, or sideways C. And then back here is trachealis muscle, which is a little bit of smooth muscle. That's in the posterior part of the trachea, and it receives both sympathetic and parasympathetic innervation. Now, when would you need more airflow? When you're sympathetically active or parasympathetically active? Sympathetic, right? Yeah, I think fight, flight. So you're going to need more sympathetic, you're going to need more airflow during those activities. So the effect of the sympathetic nervous system is actually to cause bronchodilation, or causes this muscle to relax, which makes this airway wider and more easy for air to flow. Opposite to that, the parasympathetic nervous system causes the trachealis muscle to constrict or contract, which constricts this lumen or airway, and you get less airflow when you're more parasympathetically active. Now you can see it here in dissection, you guys, where the trachea eventually splits at the carina, and this goes into the right and left main bronchi. Now the inside of the trachea is lined with a pseudostratified ciliated columnar epithelium, and the function of this is to aid in something called the mucociliary ladder. What happens is we find a lot of goblet cells that line that are in the epithelium of your trachea, and these goblet cells produce a nice thick layer of mucus. And the function of this mucus layer then is to trap debris and then move that mucus using ciliary action up and out of your trachea, where then you're going to swallow that dirty mucus, right? You guys probably don't realize this, but you're always kind of swallowing some of your saliva. Within that, you're also going to find dirty mucus coming from your airway. You end up just swallowing it, and then that gets expelled from your body through feces, which is kind of weird. This is also one of the reasons why smoking increases the risk of like colon cancer, because your lungs are helping to remove that material out of your. The cilia are helping to remove that material out of your lungs, but you swallow that material. So now it's also interacting with your gut tissue, and that can put you at a high risk for like GI cancer. Now the bronchial tree is basically a system of branching that occurs all throughout your lungs. It's a highly branched system of air conducting passages that occur after your main bronchi. And we talked about how your bronchi can split like 25 times or more before you get to the bronchioles. And the right main bronchus is wider and steeper than the left, which means that aspirated objects are more likely to enter the right lung. And this is showing our bronchial tree here, you guys. So we have our trachea, we've got our right main bronchus, and then the main bronchi split into lobar bronchi, and each lobar bronchus goes to a lobe of the lung. And then the lobar bronchi split into the segmental bronchi, or tertiary bronchi, which go to a specific bronchopulmonary segment. So on this picture up on the side, we can see that they're color-coded regions. So in green is the main bronchi, in blue is the lobar, and in yellow is segmental, and then red is just smaller bronchi. And those will continue into the bronchioles. So why is it that we only find 2 lobar bronchi on the left side? You got it. There's only 2 lobes on the left lung. And we find 3 lobar bronchi on the right because there's 3 lobes on the right lung. Good. Now, as this branching continues, you guys, what we find is that those tracheal cartilages kind of start to disappear, and the cartilage becomes smaller and less numerous. The bronchi get lined with, larger bronchi are lined with a pseudostratified columnar epithelium, but as the bronchi branch into bronchioles, we find as we get less cartilage, and the pseudostratified columnar epithelium starts to change more into like a simple columnar or simple squamous epithelium. So it gets thinner and not ciliated, and so it's actually easier for gases to be exchanged at the smaller and smaller structures of this bronchial tree. Now, eventually the bronchi branch into bronchioles, which are less than 1 millimeter in diameter. You can still see a bronchiole with an unaided eye because our visual resolution is about half of a millimeter or so. So you could potentially see a bronchiole without a microscope. But these bronchioles are relatively thick-walled with lots of smooth muscle, and they're involved with bronchoconstriction and dilation. This helps affect airflow into and out of your lungs, right? And it's smooth muscle. So which branch of your autonomic nervous system causes bronchoconstriction? Parasympathetic, good. Because if you're resting, you don't need to have a lot of airflow. And bronchodilation is mediated by your sympathetic nervous system, because if you're fighting flighting, you want to have bronchodilation to get more airflow, less resistance, more airflow along your airways. Now these bronchioles eventually branch into terminal bronchioles, which are the last portions of the conducting part of your respiratory system. Beyond the terminal bronchiole, then we have the respiratory bronchiole, which is the first part of the respiratory portion of your lower respiratory tract.